Hello everyone, I am Dr. Richa Singh, Senior Infertility and IVF expert from Max Healthcare, and I'm now available in Lucknow on every weekend. So I welcome you all to this live session of Urvara and on the Saturday evening. Urvara is basically focused on giving you the right information for the patients who are struggling with these problems so that you can choose your treatment, your center, your doctor wisely and maximize your chances of success. So let's begin the today's session which is basically on the topic azoospermia. This is a very common problem patients are finding these days because when they go for the treatment and they are basically investigated by a doctor and they're asked to give this sperm sample, then when there is no sperm, this is called as a condition called as azoospermia, and that's where the whole troublesome situation for a man begins, because we all know when there is no sperm, how will they conceive, how will they be able to father their own child? So, this is a session which is going to give hope to such couples that azoospermia is not the end of the story. And there are a lot of treatments which are still possible with this problem. And there is a possibility that you can have your own child. Before that, let's understand what actually azoospermia is. Most of the time, what happens is that there is only one report which gives you that there is no sperm in the sample. So the point to note here is there has to be minimum two reports at a difference of minimum of 2 weeks, which indicates that there is no sperm sample found in the sediment of a centrifuge sample. So this is very important because when the sample is screened, your semen sample is screened, and when there are no sperms, ideally it should be centrifuged and the pellet should be examined. And if the sperms are not found in that pellet also, then you are diagnosed as azoospermia. And sometimes when the semen analysis is negative but there are presence of small number of live sperms in that pellet, that is called as cryptozoospermia. So your diagnosis should be very important. That's why getting it checked second time with a reliable lab or from an NABL accredited lab is very important for establishing your diagnosis. नेक्स्ट जो दिमाग में चीज़ें आती हैं that why it has happened to me, what is the cause of my azoospermia, because this is what is a shocking thing for them. So here the azoospermia could be at three levels. Either it could be the pre-testicular, the testicular, or the post-testicular. Means in the pre-testicular cases, here the secretions from the hypothalamus and the pituitary from the brain, which stimulate the LH and FSH hormones and produce the sperms, are actually deficient. और ऐसे केसेस में जहाँ पे हार्मोन्स ही नहीं हैं, मे बी कंजेनाइटल डेफिशिएंसीज हों जैसे कि कैलमैन सिंड्रोम हो या आइसोलेटेड डेफिशिएंसीज हों, so there are no sperm production. Also to note that pituitary insufficiencies, high prolactin, exogenous hormone supplementation is also one of the causes. बहुत बार देखा है जिम में लोग स्टेरॉइड्स लेते हैं, एंड्रोजन्स लेते हैं, otherwise also they take supplements like estrogen, progesterone. All these are causes of pretesticular azoospermia. Now, testicular azoospermia is a condition where everything is okay, but there is no production of sperms in the testis. And that's basically because of the chromosomal problems, which is the most common is the Klinefelter syndrome and many others. Important to note is there are non-chromosomal causes also which causes spermatic failure. And this is like varicocele, cryptorchidism, Sertoli syndrome, any exposure to chemotherapy, radiotherapy, and most importantly, any infections or mumps, because all these infections cause orchitis and leads to spermatic failure. Then post testicular causes means that the production is there in the testis, but the track which is there to lead the sperm from the testis to the sample is blocked, and that blockage could be congenital or it could be an acquired, or it could be associated with a genetic condition known as cystic fibrosis, or any other condition where anti-sperm antibodies are there, or there is a ejaculatory dysfunction. So you see there are so many causes of azoospermia. So how do we know that you are in which category? Because it is very important to establish the correct diagnosis for reaching to the right treatment. So here, when you are diagnosed as a azoospermia, what is the next step is to get your ultrasound scrotum done, and also your hormonal tests like FSH, LH, testosterone, and your thyroid and prolactin. So based on the ultrasound findings, usually we establish a diagnosis. So suppose if your testis is small in size, and similarly your hormones are also less in number, means your FSH is low, that means it is a hypo kind of a condition, that is the hormones itself are not releasing from the brain. So that requires a separate treatment. Second condition is when the testis is small and your FSH is high. So this is a case where it is a primary testicular failure or a non-obstructive azoospermia. Here, the management is to create the baby through IVF or ICSI rather, and to extract the sperm through procedures like TESE or micro-TESE. This we will discuss in our next few slides. And third category is where, which is the most common, is that the hormones are normal, your testis is normal, and still you are azoospermic. So here we have to do a diagnostic biopsy, and on that it gets to know whether you are an obstructive or a non-obstructive case. So if you are an obstructive pathology, then either a recorrective surgery is recommended, or there is an ICSI procedure along with TISA or a PISA procedure. This we will discuss again in the management part. So you see there are so many things possible, and similarly is the management. So in cases where the causes are pre-testicular, so we have understood that it is because of the hormone deficiencies. So if we supplement with the hormones like HCG, FSH, clomiphene, and letrozole, then there are possibilities that these patients recover from the problem, and they might have sperms in the ejaculate after a treatment of maybe 3 months or a 6 months. And this is a duration that they take for their treatment. In testicular cases, apart from the things that we have tested, it also needs additional testing of karyotyping and your Y microsome deletions. Why? Because usually the chromosomal problems in the testicular failures are associated with these two. And if there is any abnormality, they should be sent to a genetic counselor for the counseling. And similarly, in the post-testicular cases where there is a congenital absence of vas deferens or there is a cystic fibrosis, then this needs to be the need of CFTR gene, which is important for diagnosing of cystic fibrosis mutation, is very important. और ऐसे cases में usually जब IVF या ICSI किया जाता है, so PGD is also recommended because it is a genetic condition which is transmitted through the Mendelian inheritance. Now what? So how will we manage? So any patient who is an azoospermic would be treated with an ICSI procedure, which is an intracytoplasmic sperm injection, and this we have already discussed in the previous videos. So what is the mode of treatment? How do we treat you people? So in cases where there is obstruction, that means the production is there in the reproductive organ. So here a syringe is inserted, a needle is inserted inside the testis, and the sperm tissue is aspirated in the syringe. So this is called as TISA. And similarly, if it is put inside the epididymis, it is called as percutaneous epididymal sperm aspiration, which is called as PISA. So these two are the techniques which are usually done in the cases of obstructive azoospermia. As you can see in this picture, that in first one, the needle is going in the testis, and the third one, it is going into the epididymis. While in TESE is the sperm extraction. Here the needle goes into the seminiferous tubules and the sperms are recovered from seminiferous tubules. in spite of the entire testis. So there are two procedures here in non-obstructive. There is a procedure called as TESE and there is a procedure called as micro-TESE. So cases where spermatic failure is there, TESE is done, but it has a success rate of 20 to 60% depending upon the patient's response. However, in micro surgical sperm extraction, the TESE results almost reach up to 40 to 70%. And it is much better than the procedures like TISA that we discussed in the obstructive pathology. So we usually prefer micro TSA at our setups because, of course, here the entire operation is done under microscope, and a nick is made in the testis, and the tubules are looked for the dilation, and that portion which is indicative of spermatogenesis is only taken out, and instead of the entire big chunk of tissue. So this is the difference, that in conventional TSA, almost a major tissue, maybe 65 mg is removed. However, in micro TSA, since it's quite precise under observation of microscope, the tissue extraction is very less, and the amount is almost 8 to 10 mg, and it gives us the best results also. So there has been so many studies which are being done. The TESE results have been 41%. However, in micro TESE, the results have reached up to 53%. And when out of this tissue, the sperms are being found out, and that sperm, the winner sperm, is basically used for fertilizing the egg that has been collected on the day of the TISA. And then we do an ICSI, and with the help of this ICSI, because we are having very few sperms, so we have to be very accurate in the fertilization. So ICSI is done, and then by this way, a baby or an embryo is generated, and it is transferred inside the womb of the uterus. And after 15 days, we get a result positive. So I hope this session was informative to you, and it must have given you a hope that azoospermia is not the end. There are a lot of treatments which are possible in azoospermia. The only difference is that you have to take your step out and attempt for it, because any man can be a father, but it takes someone special to be attached. So you need not lose hope. No matter the entire world says no, that you will not be able to conceive, it is not the scenario. There is always a minute possibility, and you should always give it a try. So I think I am done with my talk, and so we can take up the questions if anybody is having, and we can answer them here itself. So are we having any questions here? Our team is looking into the organization of these questions which are being sent to us. You can also send these questions on our numbers which are being reflected at the bottom screen, or you can share it on a mail ID. And you can always reach us with the consultations, and we can guide you to help you having your own biological child. We have had a lot of patients who have been delivered with the help of such techniques like microtesa, TESA, and they have had their biological child of their own. So I think we will take up the questions on the contact numbers that are being taken. And thank you for joining our webinar. And I hope it was informative to you. And for any other help, you can always reach out. Thank you.